Now let's turn to a new section, public health. Like the rest of the behavioral science sections, this section is about establishing some principles that you should be mindful about. Questions on this section are more likely to test some principle rather than a memorized fact. So as we go through, I'll try to guide you towards the overarching principles to keep in mind on test day. Let's start with a discussion of disease prevention. Now, disease prevention is divided into 3 tiers and can be remembered by the mnemonic PST, which stands for prevent, screen, and treat. This also corresponds to the primary, secondary, and tertiary tiers. Now, primary disease prevention is aimed at preventing disease occurrence to decrease both the incidence as well as the prevalence of disease. So can you think of some examples of primary disease prevention? Well, examples of this would be things like the flu vaccine or hand washing. Secondary disease prevention is aimed at early detection of diseases to decrease the severity of that disease. So what are some examples of this sort of prevention? Well, secondary disease prevention include things like screening tests such as pap smears or colonoscopy. Lastly, tertiary disease prevention is aimed at reducing the morbidity and mortality stemming from the disease. So what are some examples of this sort of prevention? Well, most treatments would actually fall under this. So you would have things like chemo or surgery. Basically, any sort of treatment obviously would fall under treat and therefore tertiary disease prevention. Lastly, there's also quaternary disease prevention. And this is where patients are at risk for unnecessary treatment, and so physicians must protect them from the risks associated with those new interventions. Medicare and Medicaid are federal programs that originated from amendments to the Social Security Act. So how might these show up on the boards? Well, they might be buried in an answer, such as, because the patient has Medicare insurance, you should offer them some specific drug. This will always be the wrong answer, because you should offer the patient all of their treatment options no matter what their insurance. Medicare is available to patients over 65 years old or under 65 if they have some sort of disability or end-stage renal disease. Now, there are 4 parts of Medicare that you should know about. A is for the hospital. B is for basic medical bills. C is a combination of A and B where hospital admissions and basic bills are covered by a private company. This is also called Medicare Advantage. Some plans also include Part D, and D is for prescription drugs. You can remember the parts pretty easily. A for admission, B for bills, C is a combination, and D for drugs. In comparison, Medicaid is federal and state health assistance for people with very low income. So you can kind of try to focus on that aid element of it. You should remember that Medicaid coverages and reimbursements differ from state to state. And again, that insurance should never affect the medical advice that you give a patient. A mnemonic you can use to help you remember this is that Medicare is for the elderly and Medicaid is for the destitute. Okay, spoiler alert. It turns out that everyone dies eventually. But thanks to epidemiology, we know what's most likely to get people based on their age. Now, this may come up on your Step 1 exam in the context of a fairly vague question. For example, someone is found dead on the street, brought in by an ambulance, and the only detail you'll get is the estimated age. Then Step 1 will ask, what is the most likely cause of death? So you should study the table and memorize the causes of death for each age group. I'll talk about some of the things that are most high yield for the exam. So let's start by focusing on the extremes of life. So we have here less than 1 year old, and then on the other extreme, over 65 years old. At less than a year, what is the primary cause of death? Well, here we have congenital malformations. Babies are born that aren't viable and they die pretty shortly after birth. In the same vein, preterm birth is the second leading cause of death. What is preterm birth again? This is defined as less than 37 weeks gestation. And finally, the number 3 killer is SIDS, or sudden infant death syndrome. Okay, how about for people over 65? Well, the number one killer is, guessed it, maybe you guessed it, heart disease. And that is followed by cancer at number 2. Now, cancer shows up a few times in the chart in your book, so let's talk about it some more. So who comes in first place for cancer deaths? Well, that is the age group of 45 to 64 years old. Okay, so who else gets cancer? Well, this is the second leading cause of death for people in a couple of different groups. You have 1 to 14, 35 to 44, and lastly, as we just discussed, over 65 years old. Now, what kind of distribution does this make you think of? Well, this is a classic bimodal distribution if this x-axis was age. So you have a peak for younger people and then a peak for the elderly. Now, what is the biggest killer actually across all populations? Surprisingly, or maybe not surprisingly, it's unintentional injury. This is a huge bummer. It really reminds us of how important stressing safety interventions at home are. So things like seat belts and bike helmets and all that jazz. One of the biggest efforts in terms of reducing healthcare costs is lowering readmissions rates. A hospital visit counts as a readmission if it occurs within 30 days of the original admission, and it does not have to be for the same reason. This chart depicts the top causes of readmissions organized by the way that the hospital visit is paid for. You will notice that mood disorders shows up a couple times. You will also notice diabetes shows up a few times. So on the exam, you should keep in mind that patients with these conditions are in danger of readmission, and you should try to make sure that adequate follow-up and post-admission care is administered. A culture of safety first is extremely important to have in a hospital. In such a culture, individuals are not afraid to say that they have made a mistake and are more concerned with finding efficient solutions when mistakes occur. While this should affect the physician's mentality, on an institutional level, there should be multiple safeguards to minimize errors as well as systems to quickly detect and fix errors when they occur. For questions on the boards, if you or a colleague make a mistake, the wrong answer will usually involve blame or cover-up. And this seems fairly obvious. The right answer, however, will always be focused on principles like honesty, transparency, and again, solutions to fix that mistake. Okay, it's time for a flash quiz. What is the most common cause of death in young adults? This is something we talked about. You should remember unintentional injury. Building on the concept of safety culture is human factors design. This is one way of limiting human error by designing systems that simplify and standardize protocol. Some examples of this are consolidating medical records electronically or verifying identification with patients prior to surgery. Another popular intervention is having standardized checklists for clinicians. This was made popular in part by Atul Gawande, who wrote the book The Checklist Manifesto. The PDSA cycle refers to a process by which an individual, group, or institution can analyze whether changes that are implemented are having the desired impact. Now, in the setting of a hospital or clinic, this process should be continually implemented in order to positively impact patients. So do you know what the letters in PDSA that represent the 4 parts of the cycle are? Well, the P stands for plan. Now, this step involves defining the problem and its potential solution. Planning should involve coming up with metrics to measure. The D stands for do. This is simply implementing the plan in a way that tests its efficacy. The S is for study, and in this step you analyze the data that was collected during the do phase. And the last step of the cycle is act. In this step, you use the analysis to implement the changes you made on a large scale, come up with a new solution, or reanalyze the problem. Now, you should really think about these steps as a continuous cycle instead of just 4 discrete steps. Quality measurements allow us to assess the performance of physicians and hospitals. They can be focused on outcome, process, or balancing. Now, what do we mean by this? Outcome is measured by asking what is the impact on patients. So if we take diabetes as our example, one outcome would be the average hemoglobin A1C of patients on a service. Process measurements deal with the performance of a system and ask how well is it doing when compared to the plan. Using diabetes as our example again, this could be looking at the percentage of patients on a service who have had a HbA1c measured in the past 6 months. This would then be compared to the percentage that was supposed to have been measured based on the hospital's guidelines or plan. Lastly, balancing takes into account how one primary outcome affects or interacts with other indirect outcomes. For example, in our diabetes cohort, how many patients have hypoglycemia or cataracts? The Swiss cheese model is a way of thinking about how accidents can occur. Now look at this image. Think of each slice of cheese as a defense layer against mistakes in the system, so that if a mistake occurs here, it's stopped here. When mistakes do happen, it is because the holes are aligned and none of the defense layers are able to catch the mistake, and that's what this arrow represents. This is a helpful way of thinking about how to prevent patient harm because it shifts focus from individuals and focuses instead on systematic defenses against causes of patient harm. We've been talking a lot about safety and different steps that can be taken to try to avoid errors that lead to patient harm. Now let's talk specifically about the types of mistakes that physicians can make. What are some that you can think of? Well, some things you might have thought of include things like patient misidentification, misdiagnosis, nosocomial infection, prescribing the wrong medication, or performing the wrong procedure. Now, errors can either be active or latent. Active errors occur due to mistakes that the physician makes directly. It has an immediate impact. So something like performing the wrong procedure or patient misidentification would fall under active medical errors. Latent errors occur due to faulty processes or organizational structure within the hospital system rather than specific physician errors. An example of this could be a nosocomial infection. Now, how could a nosocomial infection be considered a latent error? Well, for instance, the physician may always wash his hands and put on a new gown prior to going into a patient's room, but the patient might still get an infection, maybe staph or something like that, from a contaminated bedsheet or equipment that wasn't properly sterilized. Again, no matter what the cause of the mistake is, on the boards and in actual practice, disclosing the truth to the patients is the right thing to do. Of course, despite our best efforts, both systemically and individually, sometimes mistakes will happen. Now, when this occurs, we should try to understand how it happened and make efforts to stop it from happening again. Again, all of this sort of ties into things like the PDSA cycle and the Swiss cheese model. Now, there are two ways of approaching this that you should be familiar with for the boards. Root cause analysis is retrospective, in that it seeks to identify the problems that lead to an error that has already occurred. Causes can be processes, people, equipment, materials, management, you name it. In contrast, failure mode and effects analysis is prospective or forward-looking. This type of analysis seeks to identify all of the ways a process might fail in order to stop it from occurring. Okay, let's practice this with a question that you might see on the boards. You're a general medicine intern working the night shift. You're told that a patient has developed a fever overnight. You quickly order ibuprofen for the patient and continue to work on your other notes. You are later informed that the patient has developed coughing, wheezing, and shortness of breath. You check the patient's chart and discover that they have an NSAID allergy. You immediately cancel the order and help stabilize the patient. What should you do next? The correct answer here is C. Patients should always be informed of mistakes when they occur. Although you should certainly inform the attending on service, the patient must be notified as well. On the boards, consulting another physician is usually going to be the wrong answer.